good afternoon, evening. It's a very rainy afternoon, evening in UK now. It's raining very heavily outside, and it's a miserable kind of day. So it's nice to be inside today. I'm just waiting for my presentation to load up. So my name is Raja Biswas. I'm Kolkata theke, but at present I'm a consultant in Cardiff, which is in Wales, and I've been a consultant for about 16 years here now, and quite involved in the COVID management for the last 1 year. So what I was asked this morning is to talk a bit about home management of COVID. So I'll just go through a few points, and I know some of the things which I mentioned might be quite familiar to you. I do apologize for that, but I thought if there is someone who is not aware, I'll just go through the things. So can I go to the next slide, please? So I think the issue here is how bad is COVID, and there is a lot of worry about COVID everywhere in everyone's mind that it is really, really a bad infection, and if you have it, you're likely to die. There is a lot of things on television, on newspaper and everything, and I'm not for a moment undermining any of those information, but let's take it in perspective as to how bad it is. So if you have 100 people who have COVID, 86 of them will recover with minimal symptoms. They don't have to go to hospital. They will have minimal symptoms, won't need any treatment, any investigation, and probably some of them won't even know they have had COVID. I have met many people who have had COVID without realizing it. However, of those 100 people, 14 will be needing hospitalization, and that is primarily due to a low oxygen or hypoxia. Now, of those 14 people who are going to be admitted, 2 of them will need admission into intensive care because they will need intubation and ventilation. And about 1 to 5 people of those 14 people who will need hospitalization may die. Now, how many will die depends on the study which is you're looking at, depends on the medical support which you have in that country, as well as when the patient is brought in, lots of factors. In some areas, the mortality is quoted as 0.8. In some studies, it is quoted at 2.4. In some studies, it's quoted at 5%. So it varies between countries, between when you have done it. Higher number is there if you're not able to be admitted due to hypoxia. That's what's happening in India now, that because of the high patient numbers, a lot of people are not getting the oxygen. So the mortality is higher. And it can be as high as 10% if you're not getting the oxygen when you need. So of the 14 people who will be admitted into hospital, if you cannot give them oxygen, a large part of those 14 people might die. So that is the high risk which we have. Now, high risk patients are anyone who is over 70, who are overweight or has obesity, has got any sort of heart problems, especially heart failure. Diabetes, which is pretty uncontrolled, is a very big risk factor, or any respiratory conditions like bronchitis. And if you're immunocompromised, for example, if you are taking any sort of treatment for cancer, or you're on long-term steroids, that is a definite high risk factor for you. So going on to the next slide. So usual symptoms, the common symptoms, like it has mentioned before, are cough, tiredness, fever, and loss of taste and smell. We say these are the common symptoms, but COVID has been presenting in lots of different ways. I have seen over the last 1 year, patients who have presented with almost no symptoms to people who have presented with severe shortness of breath. So if you have something which is unusual and you know your body the best person who knows your body is yourself. So if you feel you're uncomfortable, that there is something wrong, you have to be aware that it might be COVID, because at this time when there's a pandemic going on, that is most likely.
Oh, wow.
Someone's playing a very nice music, which I'm enjoying, but if it can be muted, please, it will be very
Okay.
useful.
Devarati,
Yeah, I
uh,
am.
can you see who is that?
It is a
And
background music, very nice background music, but
I have muted.
thank you.
Sorry about that.
Thank you. So just going back on the previous slide. So RT-PCR is a gold standard for diagnosis. And one thing about RT-PCR, it can be negative in up to 30% of patients, which you do the RT-PCR on. So if you are unwell, and if you RT-PCR comes back negative, if the symptoms are very suggestive, a repeat RT-PCR is always recommended. Often then it's negative because it is done either too early or the way it was done was not properly done. So almost 30% can be negative. So repeat the test if you are not, if you are quite sure about your symptoms. The incubation period is also about 10 days. So before you have the symptoms, you can be infective and you can be shedding the virus for about 5 days before you get the symptoms. So if the first one is negative and you have been exposed because you have been come across someone who has had COVID, it's always better to repeat the test after 5 days because you might be having this positive test then. So next slide will just explain this a bit better. So this is the way usually the graph goes in kind of COVID. So 1 week before you have the symptom, the likelihood of being positive goes up slowly. Now it reaches the peak around the time or a day or two after you start having the symptoms and then start going down. It can take up to 90 days for the RT-PCR to be negative. However, after 10 to 14 days, you are no longer infective. What the RT-PCR is detecting is only RNA particles. So that's why there is no point in repeating your RT-PCR after 10 to 14 days if you're asymptomatic. If your symptoms have improved and if you are fine, there's no point in repeating the RT-PCR because your test might be positive, but you're no longer negative, no longer infective. Next slide. So what are the things which you need to keep at home if you are going to be looked after at home, you're staying at home? The things are, one is you should be having adequate amount of paracetamol or crocin, thermometer obviously, which most people have. Pulse oximeter nowadays, everyone almost has in their own houses. If they don't, I would recommend that should be something which you should try to get hold of because it is going to be quite useful. And obviously a contact number for a doctor or a hospital or somewhere whom you can get admission, which is often a very challenging thing. Next slide, please. So regarding the pulse oximeter, it's important to get a saturation done every 6 to 8 hours if you are COVID positive. When you are doing the pulse oximeter, try to remove any nail polish or varnish and when using the pulse oximeter. If you have very dark skin or you smoke quite heavily, the pulse oximeter can overestimate the amount of oxygen in your blood. So if it is showing a very high level, be a bit careful about it. And if your hands are very cold, it can underestimate. So be careful about the oxygen saturation. It is not absolutely accurate if you are not feeling very well. Now, the other area where you can sometimes use it are the earlobes, just here, which can be very useful to measure your oxygen saturation. If saturation is going down or below 94%, there needs to be an urgent medical advice or hospitalization. Don't waste time trying to stay at home if your saturation is going down. A 6-minute walk test is sometimes useful to have a functional assessment of your respiratory condition. So to do that, you measure your oxygen saturation at the baseline. You walk for about 6 minutes. Try to do it again in a very long corridor or a room where you can walk a bit so that you don't have to turn around very quickly. Walk at your own pace. There is no fast or slow pace. Just walk as you are comfortable. After you have walked, test the saturation. And if there is a 3% drop out of your saturation from the time you started, or you're unable to complete the 6 minutes walking due to breathlessness, then you should try to get some help. And if the saturation is below 94%, you should be contacting a doctor. During home management, if you are staying at home and you don't have to go into hospital, and this is, as I mentioned before, almost 86% of the patients who have COVID, monitor your pulse, temperature, and saturation every 6 to 8 hourly, and try to keep a record, try to note it down. What is it? Because that will be very useful if you need to come into hospital, as well as to see how it is fluctuating. Take paracetamol 500 milligrams or 650 milligrams 6 to 8 hourly, depending on if you have a temperature or if you have a lot of body aches or headaches. If you have a lot of cough, avoid lying on your back. If you want to sit up on your side, or it sometimes is helpful. Before you take a cough syrup, try a spoonful of honey, because that is often much better than a cough syrup. Cough syrup often has got codeine, and I'm sure Arjun is on later on, and I'm sure he'll agree with me on that. If you are very breathless, keep your windows open if possible and avoid using fans, because if you are using fans, the virus has a chance of spreading widely. Sit upright in your chair, and sometimes if you are severely breathless, you can do proning, which is lying on your stomach. Basically, what it does is if you're lying on your stomach, the heart does not press so much on your lungs to a slight extent, and that can relieve a bit of the breathing difficulty which you have. If you're feeling very sick and almost vomiting, you can try Domstal or domperidone, which is 10 milligrams once a day for nausea. Budesonide inhaler, which is has got some evidence regarding symptoms, is Budicort, is 800 microgram, which is about 2 puffs you have to take 4 times a day, or 4 puffs twice a day. That can be helpful. Drink plenty of fluid. Make sure you are well hydrated, which is very, very important. You can gargle with a semi-warm water. Steam inhalation is sometimes useful, but be careful, not very strong boiling water so that you don't scald yourself. A nutritious diet. There's nothing which is you shouldn't be having, but make sure you're having a nutritious diet. And try to do a 6-minute walk at least twice a day, just to make sure that your saturation is not too bad and your physical respiratory function is good. Next slide, please. So what are the signs of worsening when you should be seeking for medical review or hospitalization? It's at a time when you have a persistent temperature, when your temperature is not going down in spite of taking paracetamol. Your saturation is going down and often reaching a level of around 94%. Don't wait for anything else. Call for help. Constant cough, which is not getting any better. In fact, it's getting worse. You're getting more and more breathless. You're feeling more and more breathless. Check your respiratory rate. Like, get someone else to check it, because if you are checking it yourself, you often become very anxious. See if someone else can check your respiratory rate, how many times you're breathing in a minute. If it's more than 20 per minute, then it is something to worry about. And if someone finds that you are getting more confused, or there is reduced urine output, that is often a time to get help. Or if you have someone at home who is having that, that is the time to get help. Next. Medication. There is no proven treatment for non-hospitalized patients, and in particular, things like hydroxychloroquine, azithromycin, doxycycline, vitamin C, D, zinc, favipiravir, ivermectin. Nothing has got much of evidence. Ivermectin is still under review. Oh, sorry, just go back. Ivermectin is still under review, but at the moment cannot be recommended as a treatment or as prevention. All medical treatment should be monitored by a doctor. So if there is a treatment going on, please do not do it on your own. Get a doctor to help you. Saturation is dropping below 94%, urgent hospital admission. But in that case, if you cannot get a hospital admission because the beds are not possible, and in only that circumstances, you can start dexamethasone 6 milligram or prednisolone 30 milligrams with apixaban, which is Elquis 2.5 milligram twice daily. But I'm talking about only in a very in a situation where you cannot get into hospital and you're waiting for a bed and your oxygen saturation is dropping. But do not do this otherwise. Do not take steroids, especially if your oxygen saturation is not dropping. That is very important, because if you start steroids when the oxygen saturation is not low, it will be more harmful and the disease can get much worse. The next one. So in summary, most patients with COVID will recover with no treatment at all. So although you have to be careful, that is the bottom line. If you are careful, if you have to stay at home, take those precautions. Monitoring saturation is very important. If saturation is dropping, urgent admission into hospital is needed. Never start steroids if not hypoxic. And please, please don't start any medication without medical advice or supervision. And next slide, last slide, I think. And thank you very much. Now, if anyone wants to contact me about COVID-related medical queries, I'm very happy to be contacted. I might not be able to answer any queries straight away, but I'll try to be as helpful as I can. And that's my email there if anyone wants to contact me. Thank you.
Thank you very much, Dr. Raja Bishwas. Do anyone have any questions for Dr. Bishwas? Can you please send them in the chat, please?
Okay, someone has just asked me about the AC, air conditioning.
Yeah.
Dr. Raja Vishwa, air conditioning. So whether it's a ceiling fan or air conditioning, which one is preferable at this point?
I think the important thing is with a fan, there is a higher chance of viruses circulating a lot, especially if you have a lot of infection. If you, especially in Kolkata now, when it's very hot, you need the air conditioning, but not at a very high, not very cold, just to not make it very cold. But you remember, the problem with air conditioning, it dries also. It dries the mucus. So there is a higher chance of infection. So it kind of keeping that into mind, I think you have to be realistic. If you can manage just keeping perhaps the window open, whether that's a possibility. But at the same time, you have to be realistic as to how hot it can get in Kolkata as well.
Okay, so the bottom line is the ventilation. The ventilation has
Absolutely.
to be on all the time.
The ventilation is the bottom line. Good ventilation is very essential.
Yes. About the diabetes patients, it's like you have just suggested that patient can take honey. So what these patients are going to do if they are highly diabetic with their cough syrup or honey?
When you are taking the honey, it is only for a very short period if you have got a very bad cough at that time. So I'm not asking honey to be taken long term, but for a very, very short duration and just to relieve your symptoms. Now, for a short duration, if your blood sugar goes up slightly, that is not as bad if you are being constantly coughing and you cannot expectorate anything. Again, it's a question of how bad your diabetes is. If your diabetes is totally out of control, then you have to be careful about the amount of honey you're having. But in that case, codeine cough lincters can be an option. However, to be aware of the thing, the cough lincters, a lot of them have codeine in it. So it just dries up the secretions quite a lot.
Right, Dr. Shobhashaji, I can see you have just written me something about cutoff oxygen saturation for steroid based on recovery trial. Do you want to just explain what was that?
Went through the trial reports. It doesn't mention. It mentions that start steroids in hypoxic patients, but there was no cutoff mentioned. The only thing I could find that in some literature they mentioned about 90%. Going if the saturation going by 90%, then only start steroids. But in actual sense, are we doing that? I think the cutoff is some doctors are making it 94, some are 93%. So what would you suggest? Should we go according to recovery trial, or should we be more proactive and start the steroids even on 94, 93%?
In UK, it was being used on 92%.
Okay.
And 94%, I think, is the valuation which is used often based on NIH recommendations. I think if your saturation is dipping and going down and it is reaching a 94% level, I think steroids will definitely be useful. Whether it's 94, 92, or 90 at that stage, I don't think makes too much of a difference when your saturation were on the way down. I think it's a trend that is important rather than an absolute number.
Right.
I think Dr. Shruti Basu had some questions.
Raja, thank you for a very lucid discussion. I think in Calcutta, we face quite a few practical problems, which probably you have not seen in UK. I have been consultant with quite a few patients who started having problem with the oxygen saturation and they were symptomatic. And though I told that you take paracetamol and make sure the oxygen saturation doesn't drop below 94%, and then they started contacting many general practitioners. And suddenly we find that most of the general practitioners are extremely specialist in COVID treatment based on 1 year experience. And not necessarily they follow any guidelines. So what happens? And they actually give a full page of prescription, including 2 antibiotics and doxycycline, even meropenem, along with some steroids. It's very interesting. These patients uses oxygen cylinder every 6 hours completely and using a bigger one and suddenly going breathless after 4 days in a very moribund condition, they then looking for a bed. And that is one of the reasons why we are seeing so many deaths where the consultant, even the best respiratory physician could not do anything. And that is a very sad situation because people are thinking that I can manage COVID at home with just oxygen and medicine from the GP. And they didn't understand that this time, this particular virulent strain is sometimes affecting the lung in such a way that deterioration just happens within 24 hours. And even with your best contacts, it is extremely difficult to get a bed in a hospital. Forget about ITU, just even a general bed, and the patients are dying here and there. Now, I do not know how to solve this problem. And very recently, 3 of my patients suffered like that. The one is still in ITU and gradually recovering. One patient has died. And I do not understand how to solve this problem because we all know that what is the evidence. We are discussing in different forums, but probably this general practitioner and do not take a cue from this discussion. And unless we sort out this problem, the mortality is not going to be decreased. Even the infection rate is gradually coming down. And what is your take on that?
Sudhirda, I cannot agree with you more. Number of people I have been contacted from Kolkata with prescriptions which go on to 2 pages is so you just feel that why are you having an antibiotic, zinc, vitamin C, vitamin D, you name it. It's all on the prescription, which is not required at all. All the things, but this is a general. I will not only blame. Sorry to say this, I will not blame the doctors all the time because there is also a feeling from a lot of people by reading something on WhatsApp or Facebook or something that the treatment of COVID, they know everything about it. I often get asked about a lot of the medication, for example, plasma therapy and things like that, which has got no absolute evidence, but someone has read it somewhere in the WhatsApp messages that it works very well, or one of the drugs like which I have never heard of works very well. And then they start badgering the GP. And what will the poor GP then do? Because if he doesn't prescribe, he'll go to the next doctor who will prescribe. You know that very well. I think it is not only the doctor's fault. I completely admit I think a lot of the doctors are prescribing which should not be prescribed, but also the expectation. And I think that's where someone like you or someone like the other people in here who are practicing in Kolkata are very important because people listen to you. People listen to your voice and they will listen and trust you. We can only do so much, isn't it?
I have one question, if it's possible. Like, can I ask one question? Because I have faced some practical problem. Basically, is of course doctors are trying to follow the guidelines, definitely. But what happens is sometimes if you just prescribe a Calpol and say that that's the only medication you need for your patient who is COVID positive, and the parents or the patients are panicking. So how can we get better just with Calpol? So for that, I think for reassurance, we sometimes have to give some vitamins and all those things. I know it doesn't work. Vitamin D, vitamin C, etc. doesn't work. But if you just give Calpol, I face many questions like, যে ডাক্তারবাবু খালি ক্যালপলে কি ভালো হয়ে যাবে? কোভিড হয়েছে কোভিড হয়েছে আমার, তো ক্যালপলে কি ভালো হয়ে যাবে? তাহলে কি অন্য কোনো ওষুধ দেবেন না? So sometimes doctors are bound to write them, but of course we should write something which is not harmful. Of course, writing antibiotics and stuff will cause more harm than good. But sometimes we are bound to write vitamins and stuff because not because that we are not following the guidelines, only because that we cannot satisfy the patients because they are getting a lot of information from various places. তো আমার পাশের বাড়ির পেশেন্ট তো 10টা ওষুধ খাচ্ছে, আমাকে খালি আপনি ক্যালপল দিচ্ছেন। So this is the problem, isn't it? There is no uniformity in treatment. So we sometimes have to write something which we may not feel like writing, but still we have to write it.
I think what you are saying is right, but these are more of a complicated social issues which we can't solve here. And I don't think I have an answer, or you have an answer, or Sudeep Dara has an answer. This is this goes much deeper than that. All I can do is tell you what is the evidence for this. Now it's up to individual people to either follow the evidence or look at the overall how they want to do the practice. But I take your point. It is always very challenging to do one and expect people to trust you on that.
Yeah, that's true.
I think from the COVID first wave and COVID second wave, and there is a definite change in the trend. The COVID first wave, we saw lots of asymptomatic, and the usually idea was that if they don't develop the symptoms with the day 10 to 12, usually by day 14, they'll be out of danger. But this time there is a complete shift. Sometimes the patient is having more fever, 101, 102, even 103 on day 9, and they are having this respiratory problem later on. And what I have observed from my friends, patients, colleagues, and Raja will be able to vouch for that. But this time that respiratory infections or the pneumonia is happening too quickly and not giving the chance. You're starting the steroid, and then when to start the steroid, whether it is too early or whether it's too late, there's a very, very thin line. It is very, very difficult to identify the thin line, the ideal time to start steroid. Yes, it is right. But I have seen that many times the patients are being treated with the steroid, just thinking they're going to develop a very severe hypoxia and lung damage. And they're giving a high dose of steroid. You do not believe what is the dose of steroid they're getting. And probably Arjun will come telling us later on that now what is the after effect we are getting. So what is, Raja, do you think that from the symptom point of view, the COVID-1 and COVID-2, the first wave and second wave is completely, or I should not say completely, it's definitely a different picture altogether. What is on take on that?
Two things about it. First of all, regarding the steroids. So if you give the steroids too early, that is a virus replication phase. So if you are giving at the virus replication phase, rather than later phase when there is the cytokine storm, when there is an inflammatory process, you will make the replication worse and the infection worse. Now, regarding your question about whether the second wave is now it's worse than the first wave, I have managed COVID from March last year, and UK had the second wave around from November till March. I found that the second wave was much worse than the first wave. People were getting ill much quicker, and they were getting into ITU much quicker. So around December, January time in UK, things were as bad as it is in India now. The only difference was because the primary care system is so strong in UK, as you well know, that's why most people didn't go to the hospital. They could be treated at home. But because that is not there in India, and because this strain is very infective, so the high numbers are going into hospital, which is completely overwhelming the hospital. And because the system is not there to cope with it, you can never have enough beds anywhere in this country, any country, to and that is a absolutely idiotic ask that every patient should have a bed. You cannot. This is once in a century kind of illness. You cannot have enough beds. It is just the system is not there. But Shobhushati, going back to one thing which you mentioned before, that you think this second wave will continue, I don't think so. I think if you look at the pandemic, all the pandemics usually with this infection, it goes up like that very quickly, which it has done, but it will come down quickly as well. So I think by like early July, you will find like in the next 2-3 weeks, the numbers are coming down because A, you have gone into a lockdown, B, people will be becoming much more. Things will stabilize, but around September, October time, you will have another third wave. You are bound to have a third wave, but there will be a gap between that, which will, I think this wave will subside by mid-July, end July, and then you will have another wave around October, November, when it gets slightly cooler. That is my perception. I may be wrong, but that is my thinking.
Okay.
You-
So even if you think that we are not getting enough vaccinated, people are not getting vaccinated, still they will go down.
Vaccination will increase, but because there is not enough vaccination, the third wave will happen. But because of the lockdown and everything that is going, the social distancing, the numbers will come down. But then because there is not enough vaccination, the numbers will keep going up again.
Right.
Right. I think I have got some questions from Mr. Jayashankar. Is it necessary to keep an oxygen concentrator at home, considering the pressure in the hospitals?
If you ask me for as a thing, no. I would say certainly no, because oxygen concentrators are in short supply everywhere. So if you have to give oxygen concentrator, it should be by and two things you have to remember. If you are needing oxygen, if you are getting hypoxic, you should be going into a hospital as soon as possible, because a lot of people who are needing oxygen has to be going on to the CPAP or NIV and going into ventilation after that. So the best place for them is to go to hospital. Number two is, if you have a concentrator, it has to be monitored by a doctor and a team. So giving it at home will give you a false sense of security. And like Shudipta, I think, said before, when you deteriorate so quickly after that, because your saturation cannot be maintained, you will not have the time to go into a hospital. So going into a hospital, if your saturation is dipping, is the right thing. If you're needing oxygen, you should be going to a hospital.
So there is another question. So if there is no oxygen concentrator or oxygen cylinder at home, what a patient can do at home at that point? Is it proning, ventilation? What sort of thing they can do to manage?
The proning is one option, but yeah, if you had enough oxygen concentrators everywhere, that might be a good option to have an oxygen concentrator or oxygen cylinder at home. Do we have that? I don't think so. If you want to help in any way, proning is certainly a very good way, trying to relieve some degree of breathlessness. Number two is ventilation. But these are all stopgap measures. These are not measures which will stop you from getting hypoxic. Now, if again, going back to Jayashankar's question, if you have, if every person keeps an oxygen saturation at home, will that be enough? But if you keep it at a centralized point to be used by a lot of people, which can be used as necessary, that may be another way of looking at it. For example, I know Jayashankar lives in a multi-storied building. So if he has got one oxygen concentrator or two oxygen concentrators in a multi-storied building, which can be used by any residents who might be feeling that way as a stopgap kind of bridging thing before they go into a hospital, that might be an option.
Yeah, I mean, there should be some justification at the end of the day, whether we can stock it up or not.
Exactly.
So stocking of medicine or stocking of oxygen concentrator or oxygen cylinders is not the way that we can deal with this pandemic at this moment.
No.
Okay, there is one more question from Kollol Kumar. Does the oxygen cans help in any way?
Sorry, oxygen?
Oxygen can. There are like little cans which I can see.
Portable oxygen cans.
Oh,
Yeah,
for portable
portable
oxygen can. I think that's the same thing as I mentioned with the regarding oxygen concentrator. It's the same kind of answer. Like, for example, I've seen in a lot of places, and obviously in Calcutta, you will be familiar with it, the oxygen langar and things like that. Now, my personal view is, how is that helping? If you are not needing oxygen, you are going into a langar and having oxygen for half an hour, how is that helping your lung function or saturation or function? It's not helping you, because it should be reserved for only when your oxygen concentration is going down, not at other times.
Okay, conscious of time, I think there's one final question regarding home management of COVID. When do we know that we need to go for blood test and CT scans? Is that a necessary, or there are certain symptoms that will indicate that we need one?
CT, high resolution CT chest is reserved, should be reserved for a very specialized, should be reserved for only very limited indications. You have to remember, high resolution CT scan exposes you to a very high dose of radiation. It's not an absolutely safe thing. It is, you're exposing you to a high dose of radiation. What for? Most of the time, a chest X-ray is more than enough to diagnose or treat COVID. If you need a high resolution CT scan, you are thinking that there's a blood clot in the lungs, or you have got quite severe infiltrates into the lung, which is causing a saturation to drop. In both conditions, you should be in a hospital. And Sudipta, I think, had a question.
Raja, quite a few patients are getting better discharged from the hospital, then they are dying very abruptly. Okay, so it doesn't still fall in the domain of the long COVID syndrome because it is happening within the next 1 week, 2 weeks. And this is just happening very frequently. Almost we are hearing it every day. Have you seen this type of phenomenon there, or you think that is very typical of the second wave and in India?
I think it is. In fact, I have lost about 2 of my friends around my age with this kind of thing, who went home recovering from COVID and suddenly died. I personally think that because, as you know, COVID is a very prothrombotic kind of condition, which causes clots everywhere. I think there is a high incidence of PEs happening once they go home, because when they're in hospital, they are having the Clexane injection. Once they are going home, they are not having any sort of anticoagulation. But at the moment, the recommendation for anticoagulation after discharge is very not very clear. There is some study going on when they are doing a randomized controlled trial of giving anticoagulation following discharge and not giving the anticoagulation, but the trial results are still waited. My personal view is that if someone has got oxygen for more than 24-48 hours in the hospital, and if they have been bed bound and staying for more than 1 week, they should go for some sort of anticoagulation like apixaban 2.5 milligram BD for at least 4 weeks after discharge. However, at the moment, the evidence for that is not very good, but there are some studies and some recommendations, especially from National Institute of Health, who are recommending that you should go for anticoagulation following discharge for 4 weeks. And the British Thoracic Society also has come out with a guideline which says that if you are at a high risk, you should be on anticoagulation for 4 weeks after discharge. So those are the kind of recommendations I would really go for.
I think one problem with what's happening, sorry to interrupt, one problem is happening, we are more focusing on HRCTs in India. I think if you want to diagnose a PE, we're going for a CTPA, isn't it? And that's not happening regularly. So if you have a CTPA before discharge, that will be more reassuring than having a CT scoring, because CT scoring itself hasn't got any value, isn't it?
No.
So it doesn't change the prognosis or anything.
Okay, I guess we are almost on time. So unless anyone have any other question, and if you do have questions later on, I'm just pinging Dr. Raja Vishwa's email ID on the chat. So please feel free to send him a note if you've got any further questions.